not at the microphone, so you're good.
All right, well, everybody, welcome to our presentation. As we said, rules of the road for publishing quality improvement research. This one is very much geared for the non-researcher, which is great because we've had several of those in the room, like your operations folks, your med ed folks, but can definitely be used for your research directors to help them mentor their other colleagues, like we've heard. We have another didactic, I believe at noon, that is like kind of a more for researchers, and it's implementation science 101. But for non-researchers, we find that word very scary, so we use it very little in here.
And I would say it's not for researchers, it's for people that are thinking, what in the world is implementation science?
Yes, junior folk, yes. Okay, so we'll have several of us here presenting, and these are our disclosures. So the objectives. So one, we want to define what is quality improvement, research, implementation science, and discuss the differences and overlap. So just kind of a lay of the land with the terminology. Understand how to bridge that gap between QI, a QI project into quote, a true research study. And then what are those differences between QI and, kind of traditional clinical research. Talk a little bit about navigating the process, starting with IRBs, protocols, and then going through to publication dissemination. And then actually new this year, last year we presented this, but new this year, we added a principles of medical education research component to it because we just heard there was definitely a need and an ask for that. Okay, so, bottom line up front, yes, QI can be prospective, it can be published, it can definitely be turned into research. It's all about kind of thinking ahead, if possible, thinking ahead of time, what is your intent? Why are you doing this? And what is your kind of end goal there? So we have a little skit.
So we're going to transport you back to your home institution and tell me if you've ever seen this scene.
Dr. Davis, what's going on? You look really tired and rough. How can I help?
I just had my annual review with my chair. I'm not going up for promotion this year. He says I don't have enough research and publications, and I do everything for this department. I teach, I come in on my free time, I sit on a whole bunch of committees. I just I give hours and hours. There's not even enough hours in the day. I don't know what he wants me to do.
That sounds really rough. Pause. How can I help?
Well, you probably don't get it because you're the research director, so you have all these publications and stuff. I just don't know what to do. I don't have that skill set,
Well, let's talk about that. You do a lot of work, like you said. Could you turn some of the work that you do around the hospital into some sort of scholarship? You're on the sepsis committee, right?
Well, yeah, but that's not, we don't publish that.
Well, you've done a lot of great work trying to improve our adherence to the sepsis protocols and trying to use our order sets and try to improve the care for sepsis patients. Why not start with that?
I guess I never thought about it like that, huh?
Well, let's try to work on that.
Hopefully, I think that resonates very with a lot of people.
I'm sorry. Yeah, no, please. No, we jump in. No, that's it. No. So we talk about definitions and stuff like that as far as implementation science, and then you talk about basically overall research and then quality improvement. And when we try to break down these three things, it's really kind of shaving off different parts of what the project is. The best way I can describe it is with the definitions is really to explain it in an example, right? And so Manny Rivers' paper, we're going to change the face of sepsis and do a randomized controlled trial for different treatment methods in the emergency department and see if we make a difference in care, right? The next step of that is saying, okay, I don't work at Detroit. How do I do this at wherever, at Riverside or Cincinnati, right? And so then you talk about saying, okay, they had this really cool intervention. How do I implement that intervention in my hospital system, right? And then the last part of that is that, okay, now we have all these sepsis protocols. How do I get people to actually use and adhere and get better outcomes with it, right? And so when we talk about the definitions, there are little subtle differences, but it's trying to ask the why, the how, and the what are we doing, right? And so when we talk about those three things, you just have to have an idea idea about when somebody wants to read this paper, what do you want them to take out of it, and how are you going to try to sell that to an editor, right? Like, if I read an implementation science paper, I want to say, well, it better not be something that's an unproven method. I just want to know how to take a proven method and do it in EPIC, do it in Cerner, do it in a busy ED that's a level 1 trauma center, or a rural ED that sees 25,000 patients a year, right? So you just have to try to find out, how do I implement something that's evidence-based practice? The QI is really talking about, okay, we have an evidence practice, we tried to kick the tires on it and make it work, how do we make it work better, right? And so you're speaking to a different audience, and so you have a different outcome measure, and that's why really the intent comes in, is because you have to make sure that you are still getting good data that somebody wants to read. And so when we talk about intent, we're going to talk about it more, some of the nuances between the two, but that's really the key for QI, is making sure that you are still trying to get the best high quality data, and that data matches the QI, that somebody else is having the same problem with implementation at their site. And that's going to make it a lot easier to get it over the finish line. When I turn it over.
And just to kind of continue with what Phillip was actually talking about, I think one other way to think about this is when you think about from research to implementation science to QI, it really is in some ways in the clinical realm, it's the care continuum of research. It's like, where does it actually fall? And there's different buckets and areas in which you can actually look at that. And just to kind of, think about that in the structure of a classic kind of, what do you do in order to get published? We wanted to kind of bring in the two broad sides, not focusing on implementation explicitly, but looking at quality improvement research. So in terms of the goal and intent, as Phillip kind of alluded to, it's really about quality improvement. It's about improving the care in that particular setting. You already have something in place. What else can you do? What's been working well? What's not? What could actually be introduced to help it? And how do you actually measure it to see if that actually has the intended effect? In general, in research, it's really trying to generate that new knowledge such that you're saying, hey, this is going to really have an impact on a particular outcome of something. In regards to setting, typically in QI, it's very much centered within your own institution. Research, it can vary. It can be single site, it can be multi-site, it can be international. When we think about interventions, again, the intervention in terms of QI is not necessarily the novel component, but what areas will allow adoption or improvement, hence the word, is really going to be important. So it's already evidence-based, if you will, and acceptance. So now you're actually just trying to actually say, how am I going to improve that? And there's a lot of really important knowledge that can be generated from that can be shared and disseminated. And of course, research, usually, it's novel, it's actually, innovation, but also thinking about kind of trying to establish that evidence base and or just kind of establish some equipoise. From a statistics standpoint, again, there's two different buckets. There's a lot of overlap with that, but there's the quality-based kind of metrics that we're actually looking at from a statistical standpoint, and in the research, classically Bayesian and or empiric. And then when we think about the sample, again, if you think about the intervention in the setting, oftentimes that sample in QI is going to be your local population because their context matters in that setting. And then in research, you need to have a pretty well-defined sample to kind of control, but it varies depending upon what it is that you're intervening on. Typically, one of the things that might help people to kind of get over that hump of, how does QI translate to research? In some ways, it's a little bit easier because most often IRB is either exempt, expedited, or you don't even need it at all if you actually have an institution that actually does determination of human subjects research or not. And then, as I alluded to, I think by the scenario in the skit, is it published? Sometimes it is, but what we're trying to actually really propose is that QI can be published and should be published, and then generally research is. The other thing, too, is just to kind of kick us over, building off of this kind of Venn diagram. You have research, you have implementation science, you have quality improvement. So what if this is where you are? What is it that I'm supposed to do about this? I'm at this intersection. I think this was a little bit of what JJ was. And I think that the whole point of this is that use it to your advantage. Use it as an opportunity. Get yourself published. Get yourself in terms of doing this is a wonderful opportunity because I think it helps to try to make publication and dissemination accessible to everyone, and you have an opportunity to add to the body of knowledge.
So we do also want to highlight, so we want to highlight the point that quality improvement projects can be published and are publishable and should be published, but we also want to highlight that there is a line that kind of gets drawn in QI and research, right? So if you're doing your quality improvement project and you're talking about randomizing someone, that's probably research and probably not quality improvement. If you're taking a new product or process, I mean, if it's new to your site, that's different, right? If it's been proven nationally and you're trying to bring it to your site, that's different. But if you're trying to bring in some new thing that's not, you know, a new product or device or drug therapy or something like that, or if you're doing some sort of experimental intervention of some sort, you have a hypothesis, those things are kind of gearing more towards the research side of things, and you want to be careful when you're crossing the line. We want QI to be publishable, but we also want to acknowledge when it steps over the line kind of into kind of more traditional research. And the bottom line is it's really all about the intent. There's no black and white here. You could possibly foresee something where you randomize someone and it was really a QI project, you did some quasi-randomization, you know, stepwise kind of thing or something like that. It's really about your intent. So for a quality improvement, your intent is to implement something at your site that has already been proven. Whereas if your goal is not publication you can have as the goal, but if your goal is, you know, generalization, so you're trying to generalize this to other places, that's where the kind of research and quality improvement line gets drawn. And it's ideal if you can do this initially, but it's okay if your intent changes throughout the process. And so one of the things that we talk about is quality improvement kind of falls in this kind of health systems management bucket, but we do have another kind of Venn diagram here where we overlap with policy and research. But a lot of times we talk about things going from research into health systems management, and that's where that implementation science goes in, and policy going into health systems management, where you have your compliance officers that you all love to talk to about all the place you didn't sign or your HIPAA training for the 10 millionth time. But we also want to highlight that you can take your quality improvement and turn that into research or use that even for policy development. It's not a one-way street. These are some of the guidelines that you can use. So a lot of quality improvement things are not going to be in this consort. That's more of a research kind of randomized trial. But you can use the Squire, which is the quality improvement kind of reporting guidelines. Those are a great place to start if you want to publish your QI research, is to go on Squire and read through it and frame it in, they literally give you a framework of how to literally write your paper into that.
I would say as you start with like your research directors and stuff, if somebody comes to you with a QI project, I would point them to the Squire stuff first while you're still discussing the initial idea, so that they are framing their data, framing their project to be able to fit that. Because the biggest hurdle you're going to have is that when you try to publish this, if you send something that's more QI and the people that are reading at the journal more research, they're going to be like apoplectic, right? Because they'll be like, where's the randomization? Where's the stuff, right? So you have to start with where your goal is going to be first a little bit to make sure that the project that you're designing is not going to have a big hole. Because if you have a big hole of your data and you're trying to explain it around or explain around something that you're missing from that Squire stuff, then it's going to be a hard slog to try to get that stuff published.
Yeah, and then a lot of QI stuff is also observational data. So if you have your observational data, the Strobe statement is one of the other kind of guidelines that's out there. It's a little bit more research-based. So I would encourage you, if you are doing quality improvement, to go to this Squire. They literally, journals look for this. It's an entire framework. And if you can paint your project from the beginning into that kind of framework, it'll be much easier to publish at the end. All right?
Okay, so now we're going to transition a little bit into talking about sort of educational scholarship. And so really, and I think sort of the take-home message from what everyone else is saying here is, this is really about taking what you already do and getting credit for it, right? Our little skit talked about he's not getting promoted, right? Well, scholarship is not all original research, right? And so I think everybody has that in their mind when they look at their criteria and they're like, oh, I got to do scholarship. They think I have to get research publications. That is usually not the case. So sort of in scholarship, looking at Boyer's sort of classification of what types of things can be considered scholarship relate a lot to all the types of things that you might be doing already in education. And so thinking about discovery, integration, teaching, and application, all of those are areas of things that you might already be doing and that therefore are publishable as scholarship. And then just sort of also thinking about what types of things that you do that might be education. So I have REDCap up there, like doing types of surveys, using a survey instrument as to actually doing testing for educational things that you're doing. Simulations, a lot of us are doing simulation education, right? So thinking about using that experience and opportunity and development to get that published. All kinds of curriculum designs. A lot of our med schools are constantly changing their curriculums. Our residency programs constantly changing their curriculums, thinking about how to get that published as scholarship. Other types of sort of trainings, community trainings that you might do, different things like that. So just thinking about all the stuff you already do. So then the next really question becomes, so how do I get this education scholarship published, right? There's no place to put it. Well, that's really not true. So, there are several emergency medicine specific journals that you can publish in. There are actually other broader journals that are actually, well-known, JAMA, Lancet, things like that. They actually do publish educational scholarship. Don't forget your open access. We'll talk a little bit about MedEd portal later, maybe. And then also, don't forget your specialty journals. So if you're doing a tox sim, you might want to look at a tox journal, right? So they also will be publishing it. So don't get afraid that there is no place to publish these things. So now you're like, oh crap, there's a lot of places to publish, right? So how do I figure out where what I'm doing is a good potential to get published? So Jane, Journal Author Name Estimator, is a great place to do this, right? So you can put keywords in, you can put a title in, you can put a full abstract in, and it will give you lists of journals. It will tell you how much it thinks that your topic will fit into that journal. It will tell you you can show other articles that were published that might be related to your topic. This could be a pro or a con, right? So if they've recently published something very much like yours, probably go to the next, right? So you want something similar in your field, but not exact to pick that journal. It'll tell you how much influence the article might have in that journal and different things like that. I think this is a really great place. I've had several articles that maybe didn't get published, and then you went here and you found some journal that you've never even heard of, and had good success in getting things published that way. So there's lots of tools to help you find and select that journal to submit to.
So Susan, can I just also make a comment here? So when you're publishing QI research, it is common, research in general, but it's very common to get rejected from journals. So don't a rejection is just an opportunity to apply to a better journal, right? And as someone who's dealt with a lot of rejection in both my professional and personal life, I just want to say, if you, and this is actually proven, if you submit to enough journals, eventually somewhere will accept it. It does take time and effort to do so, but if you have something that you think is publishable and you put the effort into writing it into a manuscript, you can find a place to publish it kind of eventually. So don't just give up after one or two kind of rejections. Even if they're desk rejections or they feel like they're really harsh, there is a journal that will fit and will publish.
Yeah, and I think I've also been told if you're bragging about having a first-time submission success rate, that you're not aiming high enough. So you really do want to be getting rejections from time to time, because you really want to try and stretch yourself a little bit, right? And go for that higher journal first. Most journals are turning articles around. It's not back in the day, like when I started, you might not hear for 6 months, right? So that's not typical anymore. So it's not going to slow you down to necessarily get rejected from that first submission that you do. But it's also good to use this too, because you might have the second and third in mind right off the bat, right? So that you don't have a long turnaround time for yourself. If you do get that rejection, you kind of already know where you're going next and what you might need to do if it requires any reformatting or anything like that. So then, so what do I do to really get this published, right? So my number one takeaway point is go to the journal and read their guidelines. Follow their guidelines. Know their guidelines. You don't want to be rejected because you did not comply or put something in that they require. I've seen it happen, and it's very frustrating when somebody comes to you and says, look, this got rejected, and you look at the guidelines and go, well, no kidding. Like, you didn't follow the instructions.
Right, so that's the number one complaint from, if you go to any editor panels and everything else like that, that is their number one thing that comes across that automatically triages the stuff that comes through. Like, if you didn't take the time to read the guidelines for the journal, they're already sort of put off and things like that. So that is their number one reason that stuff gets rejected, is that you didn't follow the guidelines for that journal. I know it's a pain, and that's why getting rejection sometimes hurts, because you're having to turn it around into something else with like a completely different format. It's just part of the game.
And then I also always recommend people look at some of the articles in that journal, right? Like, there is a style to all of these journals. And so, before you start writing, familiarizing yourself with what that style is of the journal that you're going after will help you and help your writing go more smoothly, help your formatting go more smoothly. We talked a little bit about how there are different rules of the road for different types of research studies. This Equator Network is a one-stop shop where you can find all of those instructions that you might want to follow. A lot of them may not necessarily be geared towards education stuff, but if you are doing something like a chart review as part of your study, like, you do want to go and follow those guidelines. There is Repose, which is actually designed more towards educational research that you might want to follow. If you are doing some curriculum development or curriculum design or stuff, you really want to make sure that you're doing some type of assessment as part of that process that's going to really help you make something more publishable than just writing about the curriculum itself, like having some type of assessment about that. And really the key, I feel like, that comes down to success in getting your educational scholarship published is your objectives, right? So you really want to take a lot of time when you're thinking about doing educational activities about those objectives. You really want to make sure that they're learner-centered, right? You want to follow the SMART, so they have to be specific, they have to be measurable, they have to be achievable, they have to be relevant, and they have to be time-based. You want to make sure that those objectives then align with whatever instructional model that you're using for that education, and you want to make sure that they align with the level of evaluation. So if you're not already familiar with Kirkpatrick, you should become familiar with them. They have a hierarchy of types of evaluation that you want to do, and everyone's like, oh, you need to get to level 4. Well, you don't. You have to make sure that the objectives that you have and the education that you have align with whatever level of that evaluation that you're going to do. And then I also think if you're going to be doing educational activities, that you should familiarize yourself with the Bloom's taxonomy, and so that your objectives are there also aligned with the classification and the specificity of educational components that you want to do. So I could do a whole lecture on that, so I'm not going to get into too much detail about that, but if you're doing educational work, you should really familiarize yourself with that. All right, pick a topic.
All right, so this is the Choose Your Own Adventure portion of the lecture. So we have 8 more topics, and we have 25 more minutes. And so we each have a handful of different topics where we've had examples of the practices that we've kind of talked about earlier and kind of introduced you to. So we want to give you some real-world examples of how these work. So this is whoever gets to speak first and speak loudest gets to pick the next topic that we go on to. And by that fact, also pick who the next speaker is. Opioid use, all right.
That's me. Alrighty. Well, so thanks for breaking this one. So this one is basically going to talk a little bit about some of the splitting of hairs or some of the intent and why we're otherwise publishing. So this first paper actually is really more of an implementation science, right? But this is going to fly into the QI, which is the next paper based on this, right? So this is where I'm going to kind of walk you through how when you start a project, you can try to sell it into one place, and then knowing that I'm automatically going to turn it into a QI project as we have this project go on. So I'm an ED Alto recipient. That's a grant from SAMHSA, from their policy division, where they said basically we want to decrease opioid use in the emergency department. We don't know how to do that. Come up with some reasons, projects, whatever you want to do, acupuncture, physical therapy, unicorn tears, massage, whatever, and throw it in the emergency department and see what sticks. But they wanted you to use proven stuff, just that proven stuff in the emergency department. So this is really a lot of implementation science where I took ED Alto order sets, which had already been published in other areas, TENS therapy, which has been extensively studied in things like physical therapy and some of that literature. And then other procedure blocks like regional anesthesia. Again, always been shown like PANG, fascia iliaca, erector spinae blocks. Again, small studies done in emergency departments in various areas. And then basically put all of those things in my emergency department as a little bit of a buffet, and then tried to implement it and tried to support that implementation in multiple ways. So it's sort of layered. Easy to use order sets, bedside support with a physician assistant, right? And then also simulation-based training for the residents and attendings, both on shift, on demand, basically, and then through guided simulation sessions, which we are now also going to publish as part of our education projects. So the new sim models that we developed, like as far as literally the simulation models, like ballistics gel around 3D printed ribs for erector spinae block, we are already going to submit to JET-EM. So basically, when you think about the project, think about where the next level is going to go with your project, and make sure that your goals, like when I sent out this paper, the goal and the data from this paper was, these are proven therapies. I don't have to prove that they're proven therapies. It's been said here, 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 these are the outcomes that they've had in all these other areas. The sell for this paper was looking at our pre-implementation data for MMEs and overall opioid use, and post-implementation of MMEs and opioid use in my emergency department with this intervention, right? And then I don't have to tell them exactly which ones worked. I just needed to show that my data shows that there is some change in the pre and post implementation. And to make it sexy for the editor, you just try to give them maybe more months, right? So I had a year pre and I had a year post, right? And so then they really like that because the data is what's going to sell them. And so when somebody reads this, they don't want to be going saying like, I don't know how this is going to be able to be implemented in my shop, or why should I care? So the sell for me to the person is say, you're going to see this reduction if you do these interventions, and I can prove from year 1 to year 2, right? Does that make sense? So you just have to have an idea of your goal. Mine is IRB approved only because part of my study has some follow-up surveys where I'm like reaching out to patients. That was the only reason that mine was really meant to be IRB approved, because if I had to go back into the chart, get that phone number, reach out to that patient, call them, that's the real reason that this ended up having to be IRB approved. Otherwise, it's basically de-aggregated data, de-identified data, and it's overall trends across your entire emergency department. So that's the only reason that this is IRB approved. So.
There's one thing too that you mentioned that I wanted to bring up, as specifically for the 1 year pre and 1 year post. Kind of a research hack is to do a initial like brief report on pilot data. So if you don't want to wait the full year, if you have a resident or student who's trying to make a specific conference deadline, abstract conference deadline as an example, you can always publish the like initial 3 months as a brief report under that category. So it's a smaller paper, a little bit tighter paper, less words in the journal, and then you can get that published, and then wait another 9 months, get the full year's worth, and like basically kind of milk it a little bit. Totally kosher. All the research folks in the room have done that. And then you get 2 papers, 2 abstracts, as opposed to 1.
Yeah, you do an abstract, a presentation, like I mean, I have some
Yes.
people I work, yeah, you
Yes.
present it, and you can become, you can become an opioid expert and present it at your next conference. You
Yep.
already have all the background data.
Work once, get paid twice. Anytime you're going to put in a paper, it automatically goes in as an abstract either at SAEM or it goes in an abstract at ASAP, automatically. That is a hard stop. Don't even pass go. You need to do that every single time, right? Because you get, first of all, exposure, and you get to kick the tires on some of your data for some of the folks that are in the audience that hopefully show up, and you get to see what the questions are, because I guarantee you, if they have questions on the data from your abstract, those are the same questions that your editors are going to have when they try to go after it. Yes, ma'am.
Sorry, I was just trying to better understand the difference between that as the first implementation science paper. I thought it was going to just be descriptive and not the pre-post measures, but you saw the pre-post measures. So what would the second paper, how would that look different?
So based on those pre-post measures, now in my second paper, which we're writing, literally going to be submitting in week. To put in there is basically now when we look at the QI saying, okay, we saw these MME differences in this one. How did I get people to now use more of those fascia iliaca blocks? How do I get people to use the order set more? And it's me trying to change the intervention, which was initially just implementation, and trying to fine tune it to make it better. So the biggest change I did is hiring a PA instead of using a research coordinator, right? So in our first year of implementation, I had low uptake of the procedures, low uptake of the order set usage, and the biggest complaints I got from my providers at the bedside is saying, I don't have time, I don't know how to access the order set, I don't have time to set up the procedures, I don't have time to order the meds. And so I said, fine, who can I hire to actually start to order the meds, right? So now I'm showing the difference in my QI is saying, okay, I have to beef up my bedside support. It's not enough to just have someone by the bedside saying, hey, click this button, or hey, help set it up. I have a PA down there to actually start to order the medicines and then come up to the doc and be like, hey, I ordered this and this and this, and the patient's pain went from an 8 to 4. So then the doc gets credit for it and saying, oh, that's how you do that? Cool. And that now I'm gonna show the implementation and the decrease of MMEs over time, right? Given that I changed the implementation. Does that make sense?
It does. Sorry, just follow-up question is.
They want us to do this because you get.
Yeah, totally fair, sorry. Follow-up question is, do you have to follow Squire for the first study or only the second?
So I didn't yes, I didn't follow Squire for the first study. So I'm not gonna, I'll just be honest about that. And it was a slog to get it published because I had a lot of revisions. Luckily, I had an editor that really liked the paper and really was nice and generous and be like, hey, you should really do this and put this and this, and was gently telling me, you're not doing this right. So yes, eventually I did, but when I first did it was not following that same guidelines. However, going forward, the implementation, the way we're gonna publish it is following that. Does that make sense? So I learned from my own mistakes. So that's the other part about it.
So who wants to pick the next topic? Shout it out. All right, let's do it.
Okay, so this is an example of infectious disease quality improvement work that we published on. So it has been proven that EDs are a great setting for HIV screening. This is not new information. This does not need to be proven. This was proven over a decade ago. So what we specifically did here was we looked at how many diagnoses we missed if we only sampled patients who were already getting blood drawn. The idea about the impetus of this was we were thinking about all of our patients who came in after an opioid overdose who got Narcan, right? They got their IM or intranasal Narcan. They medically, clinically don't need any lab, so they weren't necessarily getting an IV, they weren't getting a lab draw. But because they use IV drugs, we were very concerned about bloodborne infectious diseases. So we were just thinking, like, how many of these people, how many of these patients are we missing because they're not getting blood for other clinical purposes. So that was the main impetus behind the study. So we had an ED HIV screening program, and we just looked at the data. We looked at the patients, and we went back and looked, okay, how many of them had a venipuncture, had some sort of other lab that was ordered, CBC, BNP, whatever, and then how many of them ended up having HIV who had that venipuncture, and how many did not, because at that time we had a point of care testing, so we could kind of do that comparison. The measure, so it was cross-sectional, so we looked at a specific moment in time, and it was all descriptive. It was all numbers, proportions, it was all very simple. And then going to the IRB, we were able to get it exempt because nothing about this, again, was experimental. Nothing about this was new. We know HIV is bad and we need to test for it. We know the ED is a good setting for this. And we were just looking at the data of our program. This program had been in existence for over a decade as well. So we just had, tons of data that we were able to look at. And we, put it in as initially as non-human subjects research, and they agreed, and it was an exempt study. So any questions on that? Yeah.
The other thing I wanted to add in regards, this is loud. Got it. In regards to kind of this as a QI project and the source of data, how it differs from maybe novel research or new research is that it's actually retrospective data that you're actually looking at. So you're looking at your own data to kind of help improve that. So I think that's another key point when we start thinking about how do we distinguish between QI and maybe novel research, and also to actually facilitates getting kind of exempt IRB status, or even potentially where it may not be human subjects research. Chart reviews generally will be exempt because it still is a patient, so it is still a human, but then in and of itself, it's not kind of you're intervening on them.
And to talk about this a little bit too on Kieran's stuff is there's a way to also play in the same dance space. So Kieran and I published in the same space as far as HIV, and I have myself my own QI paper on missed opportunities for HIV screening, it taking a different slant to this, right? So instead of looking at venipuncture and missing a venipuncture, mine was looking at missing screening at all, looking at my hospital system where I have sites that have protocolized opt-out screening and then other sites that don't, but we're the same same ED physicians that work at those shops, and then looking at my own data introspectively when I saw this and said, oh, I need to look at missed opportunities in my own shop and saying how many times was I not drawing blood, and then basically was looking at odds ratios. If you went to one of my community EDs that doesn't have opt-out versus my main level 1 trauma center and stuff like that that has opt-out screening, what are your chances that the same ED doc, even though they're exposed to that, doesn't have an HIV test? And the odds were like 4 or 5 times. Like if you go to a community shop, they just don't have time. They don't want to do it, right? So that don't feel bad that this was done, that you don't have a way to publish it, because that mine still got published because I'm in a different shop, right? I can sell it as I'm in the South and she's in the Midwest, and right? And so everybody wants to sort of take a look at that in different ways because you can find a way to speak to a different audience on a slightly different topic. So don't think that just because something was done that you can't have a voice and get some of your data as published. It's really just trying to find a slight nuance, a slight difference to make that sell happen.
Just as yeah, you can go back to the choose your adventure. Just as a quick question, because we've had a few new people come in, who is like operations focused here? Okay, like medical director, or you, yeah. So you have like all of the dashboards in the world available to you, right? Like when I meet with my ops people, they're just like clicking around, slicer, dicer this, and reports that. And so you literally have all of your like hospital systems data, EDs data. It's usually aggregate, so like, built together, like lumped together and de-identified, which is one, great for IRB purposes because you're not getting individual patient level information. You'll hear the term PHI. So it's patient health information, so things like name, MRN, any dates, like date of birth, things like that. But you just have all of this lump of data, and so you have a ton of like ability to be able to publish on that information. If you just kind of look at the numbers and start thinking about like what questions do I want to think about, and what questions am I trying to answer with this.
Well, and a key point there is you already have that data. You didn't ask the IRB to track your own like time to provider and your sepsis metrics and all that. Like that data already exists. So it's not necessarily the I think all of us would agree like the less you can get your IRB involved, the easier it is to get those things kind of done. I'm not saying to like skirt your institutional policies or whatever, but the less the IRB has to be involved. Like if you can get it to be the easiest is to not have to even go through an IRB, but at least to just get it exempt instead of going through the whole kind of full IRB kind of thing can be a little bit more difficult. So who wants to pick next? Education, development, or assessment? Assessment. All right.
All right, so unlike the other folks, I could not just pick one article because there are way too many types of educational assessment. So I wanted to give you a couple of different takes on this. So the first one, effect of a targeted quality improvement education on opiate prescribing. So I think this was interesting too because this kind of shows that you can kind of cross your quality work with your education work as well. So at our institution, they decided that they were going to have a mandatory opiate prescribing education for everybody at the institution. So we were wondering, did that have any impact on opiate prescribing at our institution? So we looked at a pre-post analysis of all of the opiate prescribing across all of the specialties at our hospital, and we looked at overall rate of prescribing, we looked at maximum daily dose of prescribing, and then we also looked at compliance with CDC prescribing guidelines, and we looked at that as a whole institution, and then we also broke that down by each specialty to look to see if there were any specific differences in impact of that training And we did decrease our overall prescribing. There were some interesting things where some specialties actually did better and some did worse with their maximum daily dosing and their compliance with CDC guidelines after training, however. So I think that also shows there was some room for improvement, maybe institutionally with our education that we provided people. I think we did overall have really pretty good compliance with people taking the education, so that really wasn't the issue related there. But that sort of shows you how these kind of QI and education can commingle themselves together as well, and a little bit of assessment of a before and after. And then I don't want to give anyone PTSD, and we're all sick of talking about COVID, but I did pick this article because it's a survey study, and everyone's like, well, you can't get survey studies published, but you can. I also picked it because we sort of talked about get credit for what you do, and this was committee work, right? So I sat on the New York ASAP Research Committee, and we were all sitting around during COVID saying, what should we do? And we said, well, you know what, let's find out what impact COVID had on residency training programs, education, right? Like, hey, great. And you know what's really great about this is being part of a state organization, they have access and contact to all of the PDs at all of the residency programs in New York State. So you have access. Number two, we have a pretty large committee, and so we cover a good number of the institutions ourselves, and we have friends at other institutions, right? So we got a 76% rate of getting the surveys done. So that really will help you, get your stuff published as well. So that was just a really good example of sending out a survey and analyzing survey data and using your committee work to do that and get scholarship published.
So Susan, question, the quality improvement education for the opioid prescribing, did you guys create that education, or was that education taken from another source that was already
I think it was taken from another source.
So that's the other key there too, right? You don't have to build everything on your own. You can take an education thing that's out there, right?
Yeah.
And
the institution picked the education. They didn't design it. It may have been a CDC education. I can't remember for sure. But yes, no, we did not design the education ourselves. We just took advantage of the fact that this was mandatory education by our institution and looked at a before and after quality improvement analysis of that education.
So like you said, the other side of that is that, some of the blooms and some of the other stuff that you're talking about there, the institution already ordered that stuff, right? So it's already in place. It was already a proven thing that you're dragging and dropping.
Yeah.
What you're then looking at is the outcome variables on that, which is just another level of education research, which I consider the holy grail of education research, which is not a high five after the session that everybody said, ooh, I had a great time playing around with this. Does it actually affect clinical care? Like, does it actually change opioid prescribing? Like, that's the real next level of the level 4, level 5 stuff, is that did it actually change behavior?
Yeah.
And so you just have to figure out when you build your project and everything, where's your survey, what's it coming out, and then can you add some of these outcome variables? Because again, I don't mean to speak bad on this, the education research bar is getting higher, right? And so just having a session, 10, 15 residents and a thing where high five afterwards, everybody had a level 5 Likert, yeah, you still may get that out, right? But going to that next level is really what you want to see, is because we've gone out of infancy where it's like single site, really cool thing, it's now multi-site, it's now, trying to get at moving the needle for the education. And that's technically where my education stuff is coming. Yeah, I'm going to publish on the development of that new little SIM model, but the next level is saying, okay, now I deployed education resident both as a simulation session during resident work hours and also on demand as sort of like right before they do the procedure. And is that moving the needle? Like what is, and I'm measuring the outcomes of how many procedures are being done by the residents. Now I'm trying to see like which intervention is actually driving that needle of more.
For the sake of time, let's see if we can
sorry.
get through a few other ones.
Do you think we have time to go through any more? I'm not sure we do.
Yeah, we have 5 more minutes.
Okay. One more. We got. Pick a fast talker. Diabetes it is.
Darn. Now I have to get this done in 5 minutes.
2 minutes.
2 minutes. Oh my goodness. All right. So diabetes. This is actually kind of a nice follow-on because the impetus for should we be screening for chronic diabetes in the emergency department really kind of grew out of some of our HIV work. So almost 15 years ago, we started our opt-out HIV implementation. And just to give a background, the justification for universal screening or screening in general is oftentimes based on prevalence of disease, but then also knowing in terms of where does it make sense to actually do screening. And so we've all identified, and we're kind of probably speaking to the choir in the emergency department, as it functions sometimes as a safety net where people come in to be the entry point for access to care, there's an opportunity to try to screen people. So, I mean, is it a question of mission creep in terms of now are we doing primary health care or not? But I think one of the things where the question came up was, well, what other disease process or condition actually has high prevalence? And what is the published data in terms of prevalence of diabetes of our patients that are coming in? I mean, we could probably say, 50% of our patients probably come in with diabetes as a comorbid condition, but part of it was actually screening for people that did not necessarily have that. And so this publication, which was now done, a little over a year ago or so, got published in JAMA in regards to actually just looking at the prevalence of undiagnosed diabetes in an urban emergency department setting. And so that's what we ended up doing, was adapting this after those things. What we actually looked at were measures in terms of, for this particular study, just the demographics of what we were seeing. Were there any associated clinical and social determinants of health? And then actually what was their A1C? And then our definitive kind linkage, if you will, the outcome of the screening was making sure that they could actually get linked to care. And linked to care was defined by the American Diabetes Association and combination with the USPSTF, so the United States Preventative Task Force. And really it is for pre-diabetics to get access to education on wellness, et cetera, and then for those that are diabetic to make sure that they have access to primary care. This was an expedited, partly because of the fact that we were actually doing some, we were interacting with patients in regard to that. From an outcome standpoint, some of this was, the initial part was just descriptive and actually trying to say, this is an issue that we do not necessarily have a grasp on. And I can stay to date, because we've been doing this now for 3+ years. We diagnose probably on a monthly basis about 200 patients that are setting foot in our ED with either prediabetes or diabetes. 70% are pre-diabetics, 30% are diabetics, but these are people that did not previously know, and 70% of those people did not actually know what their status was. What we've also elucidated through this are some challenges related to what's the next step beyond that. One of the things, this is ED-based, it is not real-time A1C resulting, and so trying to kind of capture those people and what is a motivating factor for these patients to, one, know their status is some of the ongoing kind of QI type of work that we're doing in regards to try to figure out how are we best able to intervene on diabetes as a condition, recognizing that it is a comorbid condition that's going to have a huge impact for population health. And so those are some of the other things that we're doing that are related to QI. What is the right approach? Is it literacy? Is it timing? Is it the setting? And I'm not convinced that, letting them know that they are a diabetic in the emergency department when they're showing up for something completely unrelated is necessarily the right time. So that's some of the work that we're doing that's ongoing in relation to kind of thinking about what are those questions that we still have that are part of this ongoing continuous quality improvement, but we're actually collecting and actually asking those questions. It's a combination of QI, it's a combination of implementation science. When we think about implementation science, oftentimes it's actually how does it actually work in the real world? What are those barriers that we're actually seeing? And I mean, the other thing I would say overall in relation to this, leverage the people that you actually have, the junior faculty. One of the great things about this in terms of getting publications is this was part of one of our new PhDs, her dissertation. And so as a result of that, 3 publications came out of this process in and of itself. So this was BPA. We wanted to validate our BPA algorithm. Was it actually capturing who and what, did it have fidelity related to that? Another was, as a result of our findings, can we actually create a predictive model to identify who are those people that we should be actually screening? Can we refine the screening parameters in and of itself? And then I'm blanking on the third, but there is another third off the top of my head. And then we also actually are looking at kind of just demographically, what does this look like? How does this imprint in Chicago when many people know South and West Side of Chicago, there are huge disparities just if you actually look at an aggregate life expectancy, but it layers on all of these, how does this type of screening reflect upon that, and what can we do, and what opportunity do we have or role do we have in population health?
All right, perfect. So in summary, we want, going back to what we kind of talked about earlier, QI can be prospective, QI can be published, QI can be turned into research if you'd like. So we have all examples of that, and it's really about the intent. Having the intent up front to recognize that your work is scholarly and it is worthy of publication, but also differentiating kind of QI from research up front with the intent of, are you looking to improve your process and happen to publish it, or are you looking to make some generalizable kind of new findings? And we've had lots of great examples of that today. Review the objectives. So hopefully we went over kind of differences between QI research and implementation science, and we talked about how QI projects can turn into research and be published, and then some of the principles of med-ed scholarship as well. Just a second plug here for Kieran and Janet's talk later on implementation science. If you're really interested in this topic, there's another talk here at 12 o'clock today. It is going to be in Phoenix Ballroom A, right down the hall upstairs. And that's all we got. So does anybody have any questions, comments, concerns, opinions, anecdotes, monologues, diatribes, riddles, stories, and or feedback? Oh, we're out of time. All right. Well, there's our contact information up there. So if you want to reach out to any of us, we're more than happy to discuss this or coach people kind of through doing this. We're very passionate about this. We love publishing our kind of projects and stuff and turning people's work into publications. And so if you need any help or are looking for that, we're always interested. Thank you.